Nearly every story this week comes back to one idea, that infectious diseases don't always advance on their own. They advance when humans stop holding the line. From Ebola in the DRC to measles in Pennsylvania, the week is less about microbes and about the systems built to contain them. Remember, infectious disease is the default. If humans do nothing, the infectious diseases will spread. They will emerge. They will increase. Risk communication, vaccine acceptance, public health institutions, even cooling tower maintenance, that's part of holding the line. And when those systems hold, humans win. Civilization wins. When they fray and where they fray, the pathogens are there waiting. They will come back. Cyclospora is sort of an exception, but not quite. There, we're trying hard. The tool simply can't find the source yet. This was something that was monitored much more closely, which I'll get to. That since ended in July 2025. But an intact defense does sometimes still have limits. So Ebola in the DRC is the third largest Ebola outbreak on record, and it is still climbing. It is still in the expansion stage. It's still a game of catch-up where we're trying to contain this outbreak. The cases are now around 1,800 with over 600 deaths. The case fatality ratio around 34%. We know that this number is an undercount, that there are more cases out there because testing still lags, even though things are getting a little bit better. We have another American that's infected. This is an American humanitarian worker with Samaritan's Purse. Those of you who remember, Samaritan's Purse was also involved in the 2014-2016 Ebola outbreak in West Africa, and some of their personnel got infected, including Kent Brantley, who was a famous physician who was transferred to Emory. What is the fate of this American? Is this American going to go to Germany, which seems likely, like the last American that got infected? Or will they be allowed to use the Ebola treatment centers that we've built in the United States at taxpayer expense? I suspect this patient's going to end up in Germany. There is a fourth province in the DRC, Tishopo, that has cases. At least one of the cases there doesn't have a travel link to known cases in other parts of the outbreak zone, which tells you likely that there is a chain of transmission there, which we expect to find, that's leading to cases in this fourth province. Healthcare workers have borne an inordinate burden. They're not only taking care of the patients, but they're getting infected. 112 healthcare workers have been infected, 32 dead. This is why it's so important that personal protective equipment is used when taking care of Ebola patients, that there are places to take care of these patients safely. And healthcare workers are kind of a canary in the coal mine that things are going wrong, that they don't have the resources they need. And not unrelated, there is a healthcare worker strike that's threatening recent progress and could stall the clinical trials that are going on to look at the monoclonal antibody, looking at remdesivir, looking at obeldesivir. All of that is up in the air if there's a strike going on. And there's a deeper failure here. This is an area that did have an Ebola outbreak between 2018 and 2020, the second biggest Ebola outbreak. But there doesn't seem to have been sustained risk communication. People's memory has kind of failed. They don't remember what happened there. And we're seeing the same resistance and the same misinformation recur. And remember, misinformation is the biggest ally of this outbreak, and it needs to be addressed. A couple of guardrails to keep in check here, or to make sure are intact. This is an area where malaria is also endemic. You don't want malaria services to collapse. During the 2014-2016 outbreak, it said that the malaria collapse caused as many deaths as Ebola. That was over 10,000. So I think it's really critical to make sure that you're not forgetting the other infectious disease problems that plague parts of the DRC. Ebola is not something that's going to go pandemic. It is very constrained in its ability to spread. The real worst case scenario here is that you've got kind of an area where it is sort of endemic, or there's like a frontier where Ebola abounds, where this is just where Ebola is common. That's what people are trying to avoid. Broken risk communication, healthcare worker strikes, transmission outrunning testing, fourth province impacted, third largest Ebola outbreak on record, endemicity as the worst case. That's kind of the sum up of Ebola. But this really is simply no longer an Ebola outbreak. It's becoming a test of whether the international community remembers the lessons from the last Ebola outbreak and wants to be proactive. So I'm going to now move to Cyclospora. This is all over the headlines in the United States. It's a fast-growing outbreak with an unknown source, no traceback, and no clear advice to give. So Cyclospora, just a little bit on it, it is a parasitic protozoal infection spread by produce. It is a produce infection, and that produce gets contaminated when water that's used for irrigation has human fecal matter in it. And it's been surging across the United States this summer. Michigan closing in on 2,000 cases. They've got several dozen people hospitalized. This seems to be 4 times higher than their report last year. There are 16 other states that are reporting cases of Cyclospora, and they can't name a common source. What we do know is that there doesn't seem to be an international travel link to this major outbreak. People who travel to areas where Cyclospora is endemic in Central and South America, yes, they can bring back Cyclospora, and that seems to be accounting for a lot of the cases in California, but not this Michigan outbreak. We are in peak season, spring and summer, and that's normal. But what's abnormal is that no one can identify the source. So there's no concrete avoid this to tell people. What do they do? What do they not do? We know in the past, raspberries, basil, bagged lettuce, those are things that people can avoid. Yesterday, I was at dinner with people and they weren't eating the lettuce on their plate because they're scared. So this is something that is changing people's behavior. And unlike Salmonella or E. coli, Cyclospora doesn't have an easy genomic traceback. Sorting its genetics was likened to reading War and Peace versus a quick read by an expert. The other thing about it is that we have this surveillance system called FoodNet. It's been scaled back significantly since July 2025. This is run by CDC. Now they're really looking only at Salmonella and E. coli. Cyclospora is optional. What role that plays, it'll be clear. It's unclear at this point what role that scale back played. Obviously, it didn't help the matter, and the fact that the CDC's reporting lags the state's reporting also is a problem. The treatment for Cyclospora is Bactrim, but oftentimes diagnosis is missed because people don't order the proper test. It's a specific stool test. And this can be prolonged and severe in the immunocompromised. This coincides with the World Cup. I don't know that there's any linkage with the World Cup. It hasn't really impacted the World Cup, but expect it into the headlines until the driver is found. Some other foodborne illnesses I wanted to mention. There is an E. coli outbreak traced to frozen blueberries from the Publix or Publix. Infant botulism cases still occur related to powdered formula. There are 4 cases been reported in this latest outbreak. Fox News is reporting a lot of beaches in the United States have swimming warnings because of high E. coli and coliform bacteria counts. In the article, it talked about the fact that you could smell the fact that there was fecal contamination of many beaches across the United States. That puts people at risk for contracting illnesses if they go into water that is fecally contaminated. I'm going to move now to measles, and I don't really think of measles as an outbreak anymore. I really think of it as an endemic disease reestablishing itself in real time. We have over 2,200 cases in the United States, and it's still going up. This is nearing the number for all of 2025, and we're just in July. About 6% of cases have been hospitalized. That's lower than last year, but it's not trivial because this is a fully preventable disease. My home state of Pennsylvania has over 100 cases, which is a modern record. This is where it's clear that measles is the default. If you do nothing, you will see those cases like what's happening in Pennsylvania occur. And we're watching real time this virus reestablish endemicity. One thing that really annoyed me is someone gave me the denominator or the population of Pennsylvania and say, oh, Pennsylvania has 12 million people or whatever the number is, and we have 100 or so cases. That's a pretty small number. But that 100 is very high because the relevant baseline is 0. So it's not, the denominator doesn't matter. And remember, every case of measles that's occurring in Pennsylvania or in the United States is basically voluntary, reflecting the fact that people are choosing a lower standard of living. So that's why I think this is something worth thinking about. And remember, development and disease are intertwined. We don't have that problem in the United States, but studies show when there's war, when there's disruption, measles cases go up. And each standard deviation rise in development tracks to roughly 1/3 standard deviation drop in measles. In the United States, we don't have that development problem, but we're choosing to lower ourselves to that level of development to pursue kind of a nihilist ideology and not recognize the value of vaccines. People's behavior is shifting because of measles. About 74,000 older adults sought to check their measles status. Do they have antibodies or not? They're spending money to manage a risk that was actively brought back. So this is changing healthcare economics as well. There are outbreaks in ICE facilities in Tucson, Arizona, for example. And these congregate settings are basically fertile ground for measles outbreaks. And as expected, we're seeing communications problems with the ICE outbreaks. I think it's really important to remember that the line against measles was already built. It was built in the 1960s when the vaccine was developed. And what's happening are people are erasing that line. And when you erase that line with a pathogen that's just waiting outside of that barrier, which was our herd immunity, which was our vaccination rate, what do you expect to happen? Going to now move to vaccine policy and preparedness. What I would say is that what's happening is the people, the institutions that safeguarded vaccines are being remade not to improve them, but to denigrate them because they're being improved by vaccine skeptics. So, for example, the Assistant Secretary for Preparedness and Response, the nominee, Mr. Kaufman, had a Senate hearing this past week. This is a person who is a vocal opponent of mRNA vaccines and hepatitis B vaccines. And you think you're going to put this person in charge of the nation's emergency vaccine stockpiles, answering to RFK Jr., who doesn't even believe in the germ theory of disease? This is nothing but kind of deliberate. RFK Jr. himself is moving to add many conditions to the COVID vaccine injury tables by fiat, probably insulated from judicial or legislative challenge, opening the door for more unfounded claims to make it really hazardous for people to develop vaccines. Lena Wen, the former Baltimore City health commissioner, had an op-ed in the Washington Post where she really documents the way that CDC leadership meddled with the science, looking at certain test designs. But the fact of the matter is not kind of the nuances or the in and outs of different ways of studying vaccine efficacy. The real aim here is to erode confidence in vaccine data. That's what it does. And I think she makes that point very strongly, that it's not so much about, oh, we could have done this in the trial to make it have more statistical validity. This could be tweaked, that could be tweaked. That's not the issue. The issue is the general public sees this kind of debate and they say, well, nobody can trust anything about vaccine data. And that's exactly what they want to do, the anti-vaccine movement. The Advisory Committee on Immunization Practices in shambles by design. We're seeing court cases kind of wind their way through. And I think what you're starting to see is the courts are kind of separating somewhat from the administration's position on vaccines. They're letting schools they're saying schools can have vaccine entry requirements. Employers can have vaccine employment requirements. And I think that's a good thing that you're seeing the courts actually defend certain vaccine policies. And kind of the absurdity of this movement is really illustrated by the fact that the anti-vaccine movement is platforming Andrea Shaw, who's a mother charged in the death of her twins with murder. She's blaming vaccines, saying the vaccine suffocated her two children. There is no biological plausibility here. And this really lays bare an anti-human ideology. This person is likely anti-human, allegedly, and the anti-vaccine movement is avowedly anti-human. Moving on to Legionnaires' disease in New York City. What we have in New York City is a growing cluster on the Upper East Side. And interestingly, it's 50 years after the disease was first described in 1976 in Philadelphia. So the latest numbers that I've seen, around 46 cases, 22 hospitalizations, and the cluster is still growing. What's happening now, remember with Legionnaires' disease, this is an industrial disease. Cooling towers on buildings, that's the culprit. They're sampling all of these cooling towers, looking to see if any of them are positive for Legionnaires bacteria, doing culturing, PCR, and then remediating those towers. I think it's going to be important to complete this work. I think that people have to know how to interpret the data. Many of them might be PCR positive, but at low level and may not be culprit. So we'll have to see exactly what comes out. But remember that Legionella thrives in warm water and building cooling towers. And New York has seen this before. There was an outbreak in Harlem last year. And obviously, Legionnaires' disease is not benign. It can cause a very severe pneumonia, especially in older people who are immunocompromised. And sometimes people can present late in their course of illness, and antibiotics may not be able to help. But the durable lesson for a city of apartment towers or cooling towers must be maintained and routinely tested. This needs to be standard of care. This shouldn't just be something that you're investigating after an outbreak. Because Legionnaires' disease is a more preventable outbreak. The technology isn't futuristic, it's just maintenance. And remember, again, the natural state of the world is not disease control. Disease control is something societies actively create and maintain. So if you're not maintaining your water towers, if you're not maintaining your hot tub, which is another source of Legionnaires' disease, the bacteria will be something that you have to contend with. A couple of last stories I wanted to mention. In January 2025, there was a fire in Los Angeles, the Eaton fire. And they had to evacuate a lot of people, put them in congregate settings, and their disease spread. 104 cases of norovirus, 56 cases of COVID, 29 cases of flu, and other cases of non-specific respiratory illness among evacuee staff members. I think that's an important thing to remember. Congregate settings spread infections, and you can have complex disasters. You have a fire, you evacuate people, you put them in a congregate setting, and disease takes hold. That's the default. You have to think that this is always going to happen, and you have to put technology in place to minimize the impact. There also was a really good article, I think, in the New York Times by Mingle talking about ticks. And one of the things I liked about this article, it was very comprehensive, was that it talked about the fact that humans are kind of in this preemptive surrender, to use the words of the article, with ticks. And we don't need to be in a preemptive surrender with ticks or anything. This is a civilizational issue. Can you master this problem with tick-borne illness? And the answer is yes. And I think that's what people have to start doing. We will start to see Lyme disease vaccines, other countermeasures against ticks that will be part of how we handle this resurgence or this increase of tick-borne disease. And not to close, I just wanted to remember that we notice all of these stories, or I notice these stories, because they're the exceptions. I'm talking about a few things, because most days vaccines prevent outbreaks. Surveillance systems detect threats. Public health infrastructure quietly, thanklessly does its job. The challenge is keeping it that way. And I think the common thread through this week, it's that civilization is not self-sustaining. The systems that protect us from infectious disease have to be maintained, defended, renewed. When they are, outbreaks stop or they don't even occur. And when they're not maintained or defended, microbes remind us why those systems existed in the first place.